Hi, everyone, and welcome to today's webinar, Orthopedics in 2023 and Beyond, Key Trends Affecting Growth and Value-Based Care. On behalf of Becker's Healthcare, thanks so much for joining us today. Before we get started, I'm just going to walk through a few quick housekeeping instructions. We'll start today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions that you have throughout the webinar by typing them into the Q&A box that you see on your screen. Secondly, today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access the recording. And finally, if at any time you don't see your slides moving or if you have trouble with the audio, just try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. So with that, I am pleased to introduce today's speakers. We have with us Dr. Will Barsoom, the President and Chief Transformation Officer at Healthcare Outcomes Performance Company, or HOPCO. We also have Rena Verdes, the President of Value-Based Care Solutions at HOPCO, and Donnie Romine, the CEO of Southeast Orthopedic Specialists. Dr. Barsoom, Rena, and Donnie, thank you so much again for being here today. And it's my pleasure to go ahead and pass the floor over to Dr. Barsoom to get us kicked off. Thank you so much.
Thank you very much for the opportunity to present to everybody and to join you today with Becker's. So as we all know, musculoskeletal care is a hot topic in healthcare today, and certainly value-based care in the musculoskeletal space, I think, has become more and more popular over the last several years. So when we think about some of the healthcare challenges, we always like to talk about the solutions associated with them. And at HOPCO, we think about the continuum of care as almost being pieces of a jigsaw puzzle. So whether it's practices, whether it's facilities, whether it's hospitals, payers, all of these can actually work very symbiotically together to solve some of these challenges that we see at the left side of these slides. So if the spend is too high, we want to drive to value. If we have a quality challenge, again, we want to improve quality and drive to value. We want to look at decreasing costs. We want to think about aligning all of the stakeholders in a healthier way around population health, and then thinking about appropriate partnerships to invest wisely in the next level of healthcare transparency and healthcare evolution. I think it's important for folks to recognize that what had been almost considered a little bit of a luxury, thinking about healthcare from a population perspective, is becoming now more and more of a necessity. So we've gone from the historical fee-for-service system, which, as you know, has led us here in the United States to be spending over $4 trillion a year on healthcare, now right around 20% of our gross domestic product, while countries around us have actually been much more successful in managing their healthcare spend. We think about shifting from fee-for-service and really starting to think about the drivers of change that will lead us to have a more aligned, incentive-based, value-based care model around population health. So again, today our fee-for-service model has led to high costs, I would say okay quality. If we look at the US across the board, comparing it to other countries like in Scandinavia, France, Italy, and certainly England and Canada, we perform okay. Certainly we're not leaders when it comes to things like infant mortality, lifespan, but we do okay. But we spend a lot of money to be okay. We overutilize, we have some of the best technologies, but again, for some of our more primary care and entry-level healthcare challenges, we're not really quite as advanced as we could be, and that's because we haven't been aligned around trying to be better when it comes to population health management. When we talk about value-based care, I think it's important to recognize that this catch-all phrase really represents a lot of different things. And we think about it in many ways as a glide path. Most folks on the line are certainly, I'm sure, comfortable with talking about or understanding the whole idea of retrospective procedural bundles. And a lot of folks probably also understand population health, right? The Kaiser model or the Geisinger model. But there's a lot of steps in between. So, there are clearly some challenges with procedural bundles. Many clinicians see these as a race to the bottom. But more importantly, I think when we really are trying to think globally, it's important to recognize that a procedural bundle still necessitates a procedure to occur for any savings and distributions to be realized. So we're actually much bigger fans of moving further down this glide path as close to population health as we possibly can be. So just to give you an idea of what we're talking about, when it comes to chronic condition bundles, we might be looking at something like osteoarthritis or low back pain. And if you combine osteoarthritis and low back pain, those actually together make up about 50% of the musculoskeletal spend in the United States. When we talk about musculoskeletal population health, we're talking about taking risk on 26,000 ICD-10 codes, which represent about 30% of all of the ICD-10 codes in the market today. So it really is an evolution for many folks from a mindset perspective, but the further to the right you can get in the value-based care mindset, the greater the opportunity for savings, the greater the opportunity to really improve quality. And I think it's important to recognize that this is not necessarily a skill set that exists for most healthcare systems today. It certainly exists at a place like Geisinger. I think it exists at a place like Kaiser. But for most large healthcare systems even, this is a foreign language. And that's because they've gotten very good at delivering fee-for-service healthcare, and to evolve into more of a population health mentality requires a very significant infrastructure to help get us there. So what does some of that kind of look like? Well, clearly, first and foremost, you need a risk infrastructure. You need to start thinking more like an insurance company. How do we take in money? How do we spend money? Where should it go? And what are we getting for that investment? And that takes very real infrastructure. For example, we utilize our own proprietary claims analytics engine that looks at utilization of various procedures and advanced imaging and specialists, and it bumps it up against national and regional best-in-class goals to give us an idea of how much of an opportunity there actually is to save money. We want to be efficient with all of our episodes. So I personally am a hip and knee replacement surgeon. I want to be thoughtful about how long my patient is in the hospital. Am I using post-acute care appropriately? Am I using physical therapy appropriately? What is the cost of the implant that I'm choosing to use? We want appropriate utilization. Are we operating on the right patients? Are we getting MRIs when we need them and not getting them when we don't need them? And then finally, focusing on prevention and wellness to try to remove, some of the need for very high-end, expensive procedures and expensive imaging, for example. As I mentioned before, one of the challenges with bundles is that to actually have any savings, you need an episode. You need a procedure to create that. So that's based on first a trigger event, which is usually a decision for surgery, followed by a pre-op workup, the procedure itself, hospital stay, post-acute care, and post-op therapy. So that typical episodic bundle, which many of you are familiar with through CJR or BPCI, these have a savings potential. That savings potential can be significant, but what's really interesting is that the surgical episode itself represents only a small portion of the entire spend for that diagnosis. So as an example, for knee pain, knee surgery only represents 25% of the total cost of managing knee pain for a group of patients. So if you work really hard and you save 10% from the cost of a knee replacement, you've only saved 2.5% of the total cost of spend for knee pain. When we look at lower back pain, it's actually even more significant. With lower back pain, for example, the surgery itself only represents 9% of the total spend. So we really do need to start thinking broader. So when we think about this, what are the different platforms that might exist to help get us to a point where we are more comfortable taking more risk and thinking more from a value-based care perspective? So from a practice perspective, value-based care can be what I call the ultimate ancillary, because we can layer it on top of fee-for-service rates, which allows the practices to continue to do well from a fee-for-service perspective, but also earn bonuses based on the quality of care that they're providing and the cost of that care. The same thing with hospitals. We actually partner with hospitals to help hospitals reduce their cost of care and improve the quality of their care so that they can also earn bonuses from things like a clinically integrated network. So this just kind of gives you a sense of various physician groups, benefit managers, tech-enabled disruptors that are out there, and all of the areas where we look for opportunities to better manage a cohort of patients and a cohort of providers to make sure that our patients are getting the right care in the right setting at the right time by the right provider. So all of these things together allow us to align all parts of the continuum, the provider, the patient, and the payer, to ensure the very highest quality of care. So with that, I'm going to turn this over to my partner, Rena Vertes. Rena is our president of Value-Based Care Solutions, and she'll talk about population health and really dive into some of the infrastructure needs, certainly more so than I have. Rena? Rena, I think you might be muted.
Yep, I am, but I'm not anymore. Thank you. Thanks, Will. And hi, everyone. Good morning and good afternoon, depending on where you are. We'd like to talk a little bit more about value-based care and how we see musculoskeletal being a critical component of robust value-based care strategies. MSK represents more than 20% of total healthcare spend. It is consistently in the top 3 categories of spend when payers or employers look at how their healthcare dollar is being spent. And more than 1 out of every 2 patients members within a population is receiving care for a musculoskeletal diagnosis in any given year. So with that as background, driving value in musculoskeletal care is critical. We believe that the delivery of evidence-based care and being paid for value rather than volume and intensity is the only way to show demonstrable reductions in cost and improvements in quality. We bring these beliefs to our managed practices and to our customers, and that allows us to support growth and market share expansion for ourselves and for our partners. With these inevitable changes, all stakeholders within the healthcare value chain can and should benefit. This includes the patients, the providers, payers, and purchasers of healthcare. The ones who lose are those who fail to recognize or are in denial that the train has already left the station. I want to share some examples of how we have used value-based care programs focused on musculoskeletal care to drive value and growth. The size and scope of the programs that I'm going to talk about vary depending on market dynamics and maturity. We push for value-based care components in all of our payer contracts with our managed practices, and we also work with payers and other risk-bearing entities to bring broad spectrum value-based care programs to all MSK providers in markets. One such example is a statewide procedural bundle program that we have with Florida Blue. We built a statewide clinically integrated network of musculoskeletal specialists, and we are managing the surgical and post-surgical care across those episodes. Initial results have shown savings when we actually see for the HOPCO managed network, year-over-year episode costs have actually declined, while for the exact same time period, year-over-year episode costs for the non-managed network actually saw increases. Improved quality and cost reductions provide value to the patients through better and more equitable healthcare, providers through performance-based incentives that are earned for participation in these programs, and Florida Blue and their customers get to receive the benefit of the lower cost through lower premiums. Another example is a statewide musculoskeletal population health management program that we have with United Healthcare in Arizona. In this program, our clinically integrated network takes risk on all care provided for all musculoskeletal diagnoses. And as Dr. Barsoom mentioned earlier, we define that in the broadest sense possible. That includes roughly 26,000 ICD-10 codes that are indicative of musculoskeletal care. And that includes both surgical and non-surgical treatments, as well as care that is delivered by all providers in all settings, as long as it has a musculoskeletal diagnosis. The scope of this type of program is the broadest that we offer, and I think the broadest that you will find in most value-based care discussions and circles. But with that broad scope brings substantial savings potential to the payers and their members and purchasers. And again, because it is so broad in scope, provides robust provider engagement. This slide shows the type of results that are achieved under these broad spectrum musculoskeletal population health management programs. They are impressive and they are material. This shows the results we achieved in an earlier program that covered about 100,000 Medicare Advantage lives and generated over $30 million in annual run rate savings. You can see from this graph, we literally were able to take trends in musculoskeletal spend prior to the launch of the program that were in double digits and increasing, and bring those trends down to a point where they were actually negative year over year. And this was all achieved over the course of a 2-year time frame. Quality improved during this time. Providers were fully engaged, earned meaningful incentive bonuses, and it was just a win-win across the board. Value-based care programs related to musculoskeletal care measurably improve quality and cost. Given the breadth of musculoskeletal care provided to patients across all settings, we're talking primary care settings, emergency rooms, facilities, labs, etc., value-based care programs can be used to ensure medically appropriate care is delivered to patients in the most cost-effective settings. Whether these programs are narrow scope, like a professional fee capitation, or the most comprehensive scope that is seen in a musculoskeletal population health program, the opportunities for quality and efficiency improvement exist and results have been achieved. We have had success moving high-value care networks to consistent use of evidence-based care pathways, which results in predictable and material savings across all musculoskeletal value-based care programs. And you can see some examples here of professional fee, population health, as well as procedural bundle programs. In order to do this, we need a robust analytics infrastructure, not only to just manage the overall program, but to accurately price the risk and ensure that we are on track. We use claims data as well as data sources like EMR and other data that we can obtain from our practices and from our risk clients to establish targets, identify specific and actionable quality improvement and cost reduction opportunities, monitor progress, identify outliers, engage actively with the network, and generate results. This data-driven approach allows us to manage a process of continuous improvement over time. Our infrastructure is supported by a team of actuaries, data scientists, clinical informatics experts, as well as clinicians who are able to all work together to combine these various sources of data, looking at things through a financial and clinical lens to identify opportunities and drive performance improvement. Turning data into actionable strategies and tactics requires the ability to break down musculoskeletal spend into detailed functional areas and categories of spend. This allows us to then drill down by provider and facility to identify variation and develop specific approaches for each area. Our model is data-driven, supplemented by clinical and financial experts who work directly with the provider network to understand root cause issues and implement targeted solutions to alleviate those root causes. We don't stop at identifying what the problem is. We start asking the questions once we've seen that there's a problem. We ask why, we ask how it can be corrected. We then, boots on the ground, work with the network to actually remove any barriers to ensure that the root cause issues are addressed and barriers removed. Oh, hold on. Fast forwarded too much. Sorry about that. There we go. We have a variety of tools that allow us to break down results for each functional area by utilization, cost, and quality. Our robust data warehouse is used to develop clinical and financial benchmarks, which when we compare to the claims drill down that we've created in our analytics platforms, allow us to see where efficiency and quality improvement opportunities exist and what the value of improving those outcomes is. This type of analysis is done for every population and network that we manage. And as I was saying earlier, it's not enough to just identify that emergency room visits are up. We're looking at where that's happening. Is it isolated to certain parts of the network? Why is it happening? What's the value of driving that, that improvement and then implementing the strategies to do so? Active management combined with data and real-time feedback allows us to create sustainable behavior change. The data insights are used by boots-on-the-ground network managers who meet with physicians and administrators to review results, discuss outliers, and barriers to performance achievement. Our clinical experts work with the network to implement standardized care pathways and order sets. We provide education through webinars and quality committees, as well as peer-to-peer coaching with nationally recognized musculoskeletal experts like Dr. Barsoom. Physician scorecards provide feedback on performance relative to specific quality and efficiency measures that are all tied to incentives. Our technology platform provides user-friendly analytics on utilization and cost patterns, as well as quality and compliance tracking. We use these dashboards and tools to identify broad as well as specific patterns that are impacting results. We review these patterns of variation in care to set targets for our network and to focus our network management and clinical outreach on the right providers to ensure that we are getting the right outcomes. We have remote care management capabilities that allow us to actively monitor patients throughout their surgical episode of care journey, ensuring that both surgical and post-surgical care and sites of service are optimized. Healthcare is changing. Patients want to be connected to their providers, and they want personalized care. To take care of our patients and our value-based care lives better, we have a digital ecosystem that powers care delivery and our value-based programs. Our digital platform allows for robust patient and provider engagement and monitoring. Working with care providers, we deploy digital tools that provide patient engagement and coaching and promote decision-making and decision support. Patient-reported outcomes are tracked and monitored to allow for quality reporting, early alert to potential complications, and triage for patients who are not showing expected improvement. Patient adherence to treatment plans is enhanced through virtual and home-based physical therapy options, and patient adoption is high due to the personalized nature of the application and care team connectivity. We actually design our applications with the patient and the provider partnership in mind. The patient perceives all of this as being delivered directly by their own provider with whom they have a personal relationship and are looking to obey, for lack of a better word, and comply is probably better, with the treatment plans that their provider is ordering. And with that, I'm going to hand you off to my colleague, Donnie Romine, who leads our Southeast Orthopedic Specialist practice.
Thanks, Rena. Let me get the slides here. So I'm going to start off just kind of setting the stage of who Southeast Orthopedic Specialists was prior to our partnership with HOPCO, and then where we've gone since that time. So if you go back to 2018, which was the year, the last year before we did our partnership with HOPCO, which was in the middle of 2019. So we're just about, next month, we're going to be at the 4-year mark. But the practice was established in 2001. It was what I would call maybe a medium-sized orthopedic surgery practice, very much focused on orthopedic surgery, very focused on all the subspecialties. We had a couple good ancillaries. We had a few locations, and during that, right about that, in that 2018 time period, the owners of the practice kind of got together and we started asking the question, where do we go from here? We have a good practice, but what do we want to do going forward? And I think the main thing these are kind of were the main drivers to our desired future state. And that was number one, how do we transition from an orthopedic surgery practice to a musculoskeletal healthcare system? We had a lot of conversations about the fact that the vast majority of people who are out there who need orthopedic or musculoskeletal care don't need surgery. They need something else. And how can we be the company that provides that something else? So how do we offer that full continuum of MSK services? Next is, how do we create an operating model that's scalable? We had a relatively small footprint, and we wanted to grow that footprint to outside. We were actually only in 2 counties. Our primary service area in Northeast Florida is a 5-county area. We were in 2, but we wanted to expand that all the way down into Central Florida and then all the way across the Panhandle over to even into kind of the Pensacola area and areas like that. So we knew we needed something scalable. The next one was the kind of a conversation around, we know that the transition from volume to value is coming. And we had to kind of make a decision. Do we want to be, we knew the train was coming. And do we want to be driving the train, or do we want to be a passenger on the train, or do we want to be run over by the train? And we decided we wanted to be, driving the train. We may not know how to build the train, but we knew we wanted to be driving it. And that's where the conversations came about, well, maybe we need a partner in this. And of course, being the aggressive people, type A's that we are, we wanted to create this market dominant organization that nobody would be able to compete with. So moving forward, and this is kind of, and I put this on here, I'm not going to read all the way through it. There's a lot of words on here, but I wanted to just kind of give that impression from 2019 till now over the last 4 years. This is just a listing of the things that we have done with our HOPCO partnership. And it's a lot. And you'll see at the end of my presentation a lot of the results that we've achieved through that. But there are a couple of things on here that I do want to kind of stress and point out. That's going to be kind of maybe the theme to what I'm going to talk about. One is, if you look on that top left where it says added specialties, we added things like chiropractic. We did not have pain management at the time. We added pain management. We added a lot of non-operative orthopedics. So this was us moving into the non-operative side of the business and going away from just a pure surgical practice. That actually connects with, if you look on the right-hand side on the top, where we talk about walk-in clinics. So we have put together what we call a hub and spoke model. I know that's nothing unique to us, but we've really focused on getting our access points out into the communities, out where people live. And I'll talk a little bit more about that later. Our partnerships, bottom left-hand corner. And you see on there the hospital service line management piece. Our partnership with the hospital system here in Jacksonville is critical. It's critical for us, and it's critical for them, and it's critical for HOPCO. Well, we have formed a really, really strong partnership. And then the last one, and this actually connects all of it together, is the enhanced market presence. That's something HOPCO brought to the table for us. And we have really created a strong presence, whether it's our presence through our website, presence through social media, our digital marketing strategy. We have a lot of things that go into all that. So I'm going to hit on those kind of as we go forward. So this one, I'm going to start with our partnership with Ascension, Florida, and Gulf Coast. So that's a system of hospitals. There are 8 hospitals now that go from Jacksonville across to Pensacola. I'm going to focus on the east side of that market, the Jacksonville market, which is St. Vincent's Healthcare. One of the things that we did with Ascension is we formed or put together this orthopedic specialty hospital. It's not a standalone facility. It's a facility. It's a hospital within a hospital, but it is branded Performance Orthopedic and Spine Specialty Hospital. So when people come in, one of the Ascension hospitals, they come into our entrance, and that what you can see on the slide there is actually the entrance to our facility. And the key to that is it is what's driving this partnership with Ascension. So a very important. In fact, I was just looking at some IntelliMed data that I just got. So I want to kind of give you. I'll just kind of give you some of the results that we've achieved in here. But I'll set the stage as well. Jacksonville is a pretty competitive market. We have 15 hospitals in our primary service area. And that's anywhere from 4 Ascension hospitals, 5 Baptist Health hospitals, a couple HCA hospitals, 2 University of Florida Health hospitals. There's a locally owned hospital in St. Augustine just south of us. And then we also have Mayo. So we have some pretty competitive areas out there. And in the last IntelliMed, with the last IntelliMed data that we just got, we have moved 5 market share points to Ascension over the last 4 quarters. And it may not sound like a lot, but as competitive as that market is, we've gone from Ascension having a 28% share of the market to a 33% share of the market. And that's equivalent of somewhere between 1,800 and 2,000 surgical cases a year. So it is really significant. And how we've done that is there's just a lot of things we've done. One is the Performance Orthopedic and Spine Specialty Hospital. Through our joint venture with HOPCO and with Ascension, we really focus on things, not just the volume, but the quality. And so our surgeons and the HOPCO team, HOPCO actually has a team here in the market that focuses on this service line. And we come together on a regular basis and we manage this service line for Ascension. And so that's what's driving that shift in the market. But again, it's not just the volume, it's also we focus on quality. And we focus on things like, first case out on time starts. We look at things like our HCAP scores around communication with the physician. We have a trauma program that we've developed with Ascension, where one of the metrics we track is what percentage of the patients who come into the ER with a hip fracture are in the OR within 24 hours. What's our 30-day readmission rate? Just all kinds of things like that. And we have driven the quality metrics beyond what anybody else in the market has been able to do. So that connection has been very very important to us. On the Southeast Orthopedic side, that partnership is important because we are connected to Ascension, and we're able to use that partnership to grow. And whether it's referrals from Ascension primary care physicians, or recruitment agreements that Ascension provides us that allows us to go out and add providers to our team. Something that and I think I've got. This is kind of what that has resulted in. And remember, if you can remember from the slide that I showed earlier, we were 60 providers at that time, and in just over those last 4 years, and this is again through a lot of combination of HOPCO work, SOS work, Ascension work, we're now a group of 120 providers. So just in those 4 years, we have doubled the size of our practice. We've added 60 providers, we've added 10 surgeons, we've added 6 non-operative physicians, we've added 15 APPs, we've added 29 therapists, we've added 5 clinic locations, and we've added 2 surgery centers. And that growth hasn't even stopped yet. We still have line of sight for more significant growth on top of that. This is our market coverage. This was SOS in 2018. 5 clinics, had a relatively decent coverage around the Jacksonville market, but nothing really significant. So fast forward to now, and you can see that our coverage area is significantly greater. We've implemented, again, this hub and spoke model where we're able to put our smaller, what we call spoke clinics. And our spoke clinics are focused on non-operative. We have a non-operative orthopedist, we have a chiropractor, and we have, some of them have advanced imaging, most do not, but then we also have therapy in each of those locations. And using some of the tools from HOPCO, we were able to sit down and look at where these new clinics needed to be located. So we run heat maps, and we're able to see where is it that we have maybe holes in our market capture. And because we don't have anything in that, maybe a densely populated part of the market that we weren't physically located in. Or maybe it was a situation of we had an area of the market that we had a lot of market capture and we needed to protect it. So we're able to start building these smaller, our typical, what we call our hub clinics, are anywhere from 15 to 25,000 square feet. That's where the surgeons hang out. We have advanced imaging. We have all those kind of things there. We have our pain management, we do kypho there, all those kind of things. And the scale down clinics, they're kind of neighborhood clinics. And the key to those, we hold those out to the community as, here's a place that's close to home. You can walk in if you'd like. If you'd like an appointment, that's fine too. We will see you within 24 hours. And what we have found, at least in this market, we transformed from a market of people being used to, I call the practice and I have to wait 3 or 4 weeks to get in to see somebody because everybody's so busy, to we'll see you within 24 hours. And it has really made a big difference for us. And this is part of how we've done that. The team at HOPCO, the marketing team at HOPCO, has helped us to brand these spoke clinics, and we call this SOS Direct or Southeast Orthopedic Specialist Direct. And all of our spoke clinics are branded with this. A lot of collateral material. We have videos that we use in some of our digital advertising. And again, this has been a real thrust of ours. And again, in a little bit, I'll show you the results of this. So we have grown through all of these initiatives. We have grown not only the footprint of Southeast Orthopedics, but we've also just grown the volume of orthopedics. And I know it kind of sounds counterintuitive when we talk about going to value. Why do you focus so much on growth? And again, I think this goes back to, we knew that there was a lot of market in our market, a lot of patients in our market that were not accessing us, and they may have been accessing our competitors, or leaving town. So we wanted to make it that access point where they could come in to see us. But then also, and you'll see when we start showing some of these results, the patients that are coming in are getting the right care at the right time. So, for example, you can see here in 2018, our practice we had 18,000 new patients in our practice in that year, and we did 9,600 surgeries. So you see that surgical conversion rate. Fast forward to 2022, we saw 64,000 new patients in our practice. And so over, a 37% year over year compound annual growth rate. I think any business would almost kill for that kind of a growth rate. But you can see our surgery growth rate was only 8.5%. So the people that we're bringing in are getting getting non-operative care as opposed to just somebody going straight to surgery. So our clinic visits have gone from, in 2018, 161,000 visits to 246,000 visits last year. I saw a question on there earlier about ancillaries. We have a real focus on our ancillaries. You can see we've gone from, in 2018, we had one MRI, and we did 4,600 MRIs. Right now, we have four MRIs. We did 14,000 last year. We're on target actually to do 23,000 MRIs this year with our same four. Two of those four we acquired in the middle of 2021. We'll be adding a fifth MRI later this year, early next year. We're not sure which we'll end up doing. DME, same thing. Therapy, you can see what's happened with our therapy volume from 46,000 visits in 2018 to 92,000 visits in 22. I think we'll hit 124,000 visits this year. We actually we order about 62,000 therapy evals every year, and which generate about 500,000 therapy visits. I wish we had the capacity to keep all those in-house. We don't. We keep adding capacity. And so that's a real focus of ours, again, with the help of HOPCO. How do we add capacity, and how do we grow and add these rehab centers that we're developing around the city? One of the things that we implemented was in-house dispensing. Again, to that question that came up about utilization of ancillaries, one of the things that we do with we have a team it's called our growth team. And their job is to identify what are things that we order out of our practice that goes outside. So with that, we've expanded our DME, we've added in-house dispensing, we've added in-house kyphoplasty. We're in the process of adding remote patient monitoring to enhance our PT. And so all of this has resulted in a pretty significant growth in the practice. You can see from 39 million in AR collections to 72 million last year. I think this year we'll end up doing about 88 million. And so again, we talked about glide paths earlier. We're on that glide path to continue to grow. Very healthy organization, and it's a lot of work. But I don't think we would have come anywhere close to these results and these numbers without our HOPCO and our Ascension partnerships. So those have really helped us tremendously. So that's kind of us in a nutshell in 4 years and 15 minutes. And so we're available now to answer any questions that anybody may have.
Wonderful. Thank you so much, Dr. Barsoom, Rena, and Donnie. Really great presentations. And I know this topic is so top of mind for so many out there, so really helpful information for us all. So let's go ahead and get started with the Q&A session. And just a reminder to the audience members, you can submit any questions that you have by typing them into the Q&A chat box. It's on your webinar console. All right, so with that, let's go ahead and get started with the first question. This one, I'm thinking, Rena, you might be best suited for this question, which is, what are the primary drivers to reduced cost trend? So examples given are utilization, pre-op preventive therapies, reimbursement terms.
Sure, and thanks for the question. So the drivers of savings and opportunity do vary in each market depending on a variety of factors. But in general, and related to some of the results that I showed in earlier slides, we see savings across a variety of levers. It's not just one single lever. We're seeing savings in appropriateness of just services being provided, and that includes a service happening at all, like maybe a surgery is not warranted or an MRI is not warranted, but also the number of services being provided. So, for example, let's say a patient is referred for physical therapy, and that's clinically appropriate. But what may not be clinically appropriate is 21 appointments versus, let's say, 10 or 14. So, we're looking at it from all of those lenses. Site of service is definitely a lever that's pulled. It is a bigger opportunity in some markets compared to others, not only in the intensity, but also, among facilities within the same category. Post-acute is another big area of opportunity still. Just unnecessary use of various post-discharge services. So clinical appropriateness and service intensity are really where we're finding the most savings opportunity.
Rena, can I add
to that,
something
Rena? Oh, sorry. Will and I both. Go ahead, Will.
Thanks, Donnie. Yeah, so what I was going to suggest as well is I think it's important to recognize many times people think about cost savings in the orthopedic surgery space and they immediately link it to less surgery. And that's not the case at all. It's actually appropriate surgery at the right time, at the right place. And I'll give you an example. As a knee and hip replacement surgeon, if I see a patient that needs a knee replacement and they have a 30-degree flexion contracture and a fixed varus deformity, I know that there isn't enough physical therapy in the world that's going to keep them from getting a knee replacement. I know that. In our protocols, you actually should operate on that patient right away. You shouldn't send them to therapy. You shouldn't inject their knee because we know it's not going to make any difference. Our programs also reach into the primary care space where we work with our colleagues in primary care that are involved in the regions where we have networks. And we ask them to work with us around things like advanced imaging. So another example would be, we published a paper not too long ago that showed that almost 50% of patients coming for a knee replacement already had an MRI that was ordered by somebody other than the orthopedic surgeon. These patients come in and they say, well, do you want to look at my MRI? And I'll look at it just to make them feel better, but I don't need to look at it because their x-ray tells the story. The MRI was completely unnecessary. So the idea of educating providers more around clinical care pathways is really a great way to A, improve communication between providers, and B, make sure that the patient gets that correct care right on the front side of it. Donnie?
Yeah, and what I was going to say is very similar to all that, and maybe kind of from the practice perspective. And I think kind of our mantra on that is it's all about what you do, when you do it, and where you do it. And so we try to look at what are we doing? This is not a orthopedic surgery practice anymore. We do a lot of surgeries. We do now 15,000 surgeries, but we see a whole lot of patients who don't ever need surgery. But to that point, and I think, and Will said this, I think great. He really said it really well. We use the HOPCO tools that we have to identify if a patient needs to go to the OR, go to the OR. And I think the payers have a tendency to say, well, you need to go through all this conservative therapy. You need to have this, you need to have this, you need to have so many PT visits and all that. But like Will said, the surgeon knows they're going to surgery anyway because they need surgery. So why don't we just skip all that and go and fix them in the OR? That's actually going to drive down the cost to the payer. And then the last thing is where you do it. And that's, I think 4 years ago, maybe 15 to 20% of our surgical cases were done in an ASC. I think now we're at about 45%. And the only reason it's not at 75%, which is our goal, is because we don't have enough ASC capacity. We have 9 ORs that we own. Over the next 18 months, we're going to be either building or buying or expanding to 19. And with that, we can hit that 75% mark. So all those things combined, and I think Rena said it as well, there's no one thing. It's just a lot of things that drive down that cost.
Great. Thank you all for that really well-rounded answer. Okay, so this next question is for Dr. Barsoom. The question is shifting TJR to outpatient contributing to higher quality and lower costs?
Yeah, that's a great question. So there's no question that it does. In fact, you know, if you, just the folks on this webinar, if you ask yourself, or if you've ever taken a family member or you yourself have had surgery in a hospital setting versus in a surgery setting, that alone tells you that the patient experience is so much better pretty much across the board in a surgery center. Parking is easier. You don't have to pay to go into a parking garage. You don't have to trek, you know, blocks to get to the right desk to get checked in for your surgery. It's just very, very simple. It's very straightforward. You can arrive a little bit later. You usually leave a little bit earlier. All those things certainly make the patient experience a lot better. Now, that being said, not every patient is appropriate for the outpatient space, but all things being equal, if you had the choice, most folks would choose having it done in an ASC because the experience tends to be better. Now, in terms of cost, there's no question that the cost is lower in an ASC. Not only is the reimbursement lower, but the actual costs are lower. Why? I used to run hospitals before I joined HOPCO. I was CEO of the Cleveland Clinic for the Florida region. And when I did that, our hospitals needed anesthesiologists in-house 24 hours a day. We needed general surgery residents in-house 24 hours a day because we had really sick patients that needed to be managed 24 hours a day. In an ASC setting, you don't need those folks. You don't need an anesthesiologist spending the night in an ASC not generating any revenue, right? So that's a pure cost that isn't necessary in a surgery center that is necessary in a hospital. So there are very direct costs associated with running hospitals that you don't have in ASCs. In addition, even just the cost of construction. In the state of Florida, where Donnie and I both live, we have ACA, which is essentially our Department of Health. It's a wonderful group, and they do a very nice job here within the state. But the requirements for construction codes for a hospital are very different than construction codes for an ASC. So the cost of building essentially the same facility, if it's hospital-based versus if it's an ASC, are dramatically different because of those requirements. So hopefully that helps to answer the question around cost.
Yeah, thank you so much, Dr. Barsoom. I think this question would be best suited for you as well. Is there a strategy to build a narrow, high-performing network of post-acute providers that also take risk and gain share?
Yeah, I mean, look, I think in the ideal state, yes, without a question. I mean, working with, when you're getting into rehab facilities and subacute nursing facilities and home healthcare organizations, without a doubt, we have partners that we work with, and in essence, their motivation is that we share with them our best practices. They're willing to utilize those best practices, and it works out very well with patients. So they end up getting some patient steerage because they develop a reputation for being the best-in-class provider and potentially a reputation of being, you know, the HOPCO partner in that region. So that's a real benefit, I think, to them, and clearly a benefit to us to have a post-acute care provider partner that we believe is best in class. So there's no question that further alignment and kind of vertical integration around post-acute care plays a very important role here. And, you know, it's somewhat subtle in some of the things that you see that make a post-acute site best in class. I would say it can range from how much therapy patients are getting, what are the protocols that the patients are utilizing, how long are the patients staying at that site versus being discharged, right? That's a big one. Just because your insurance company will pay for 21 days of post-acute care as an inpatient doesn't mean that you need 21 days of post-acute care as an inpatient. So again, working with our partners there to ensure that their beds are best utilized by patients that need those beds is a win-win for them. It's a win-win for our patients and a win-win for society from a cost savings perspective.
Great. Thank you so much. And Dr. Barsoom, I promise I will give you a break in just a moment, and I'll kick over some other questions to Rena and Donnie. But I have one more for you as we're winding down. What is the first thing an MSK practice should look for in a PE or MSO partner?
Well, I'll give you my answer, and then I'll ask Donnie to weigh in because he was on the end of thinking about things. I'll give you the first 10 reasons in one word: culture. Any partner that you bring into a practice, whether it is a partner that's an orthopedic surgery partner, right? As an orthopedic surgeon, when I looked for partners, I wanted them to be culturally aligned with me and with the other members of my department. As an organization, whether it's a practice or on our side, whether it's a practice management platform, a musculoskeletal management platform, whoever you're partnering with needs to be culturally aligned with you. And we do the same thing, by the way, with hospitals. If we meet with a hospital whose view it is that all orthopedic volume, all MSK volume should stay in their hospital and should not, then they don't want to develop an outpatient strategy around MSK care, that's not a good partner for us because we recognize that in the end, we're not going to have aligned priorities and aligned goals. So having that cultural alignment around how do you reduce costs, how do you improve quality, how do you make it best in class for patients and improve the quality of care, that's, I think, really the key. And that all comes down to culture. Donnie, what were you guys thinking about at SOS as you guys were thinking, looking for the right partner?
Yeah, thanks, Will. It was really the same thing. We went through and, we interviewed several bankers. We met with several PE firms. And I think every time, without fail, every time we finished a meeting with them, it just didn't feel right. And I think the thing that struck us the most is like Will. I mean, I come out of the hospital side, running hospitals as hospital CFO, CEO, COO for 30 years. And what I found myself sitting in front of a group of people that had no clue what I do every day and had no clue what our physicians do every day. And after the fourth or fifth one said, introduce himself as I'm whoever, and I have 28 years of healthcare experience, I found myself responding with, no, you actually have 0 years of healthcare experience because you don't have any idea what I do. And so we were kind of discouraged as we looked at that. And then when we sat down with Hopco, that all changed because with Hopco, Hopco may have private equity backing. The 4 years that I've been with Hopco, I've never talked to a private equity person one. And I talked to Rena, and I talked to Will, and I talked to David Jakovsky. And, I have two boards that I report to. One is the board of Southeast Orthopedic Specialists, which is 5 orthopedic surgeons. The other is the board of our MSO. And that board is 8 people, 7 of who are orthopedic surgeons. Will happens to be one. And so it's that culture piece is there, like Will said, because everybody has been to the same place and everybody does the same things and we think the same way. So it was a very easy decision for us once we finally found the right partner. And it was literally that night after the presentation that we had with Hopco. The decision was made that night. It was that clear to us that this is the way we need to go.
Great. Thank you so much. And I know we are right down to the wire, but I think we can squeeze in just one more question for you, Rena. The last question is, what is HOPCO doing to reduce duplication of services and enhance collaboration among all players leading up to care delivery and post-care delivery?
Another great question. Thank you. As we said earlier, our platform is designed around both a digital infrastructure as well as a deployment of care pathways and protocols that are all aligned around the delivery of evidence-based care. In order for clinicians to participate in our clinically integrated networks, they are basically agreeing to comply with those care pathways, which, by the very nature of it is ensuring that they're only doing things that are necessary one time and in the right setting and at the right time. We also work, we directly, as well as our clinically integrated network of specialists, work with upstream and downstream providers, whether it's the primary care physicians and the ER physicians upstream, or the skilled nursing facility and home health agencies downstream. We are working with them to educate them as well on appropriate clinical care as related to musculoskeletal conditions. So we have programs to educate primary care physicians on the appropriate treatment of patients, for example, with low back pain. When is it appropriate to refer? When is it appropriate to order an MRI? When is it appropriate to prescribe opioids? And all of those things and those algorithms to make good clinical decisions are deployed throughout the entire care continuum to ensure that everyone is complying and thus minimizing any real duplication and waste.
Wonderful. Thanks, Rena. Thanks especially for addressing that question in such a condensed period of time. So thank you, Dr. Barsoom, Rena, and Donnie for your excellent presentations today, and also to our audience for your engagement and the excellent questions. And lastly, we'd like to thank HOPCO for sponsoring today's webinar. To learn more about the content presented today, please be sure to check out the resources section of your webinar console and fill out the post-webinar survey. Thank you all again so much for joining, and we hope that you have a wonderful afternoon.
Thank you.
Thank you.